Welcome to Global Development Interrupted. I'm Leah Petit, your host. If you're interested in learning how global development affects Americans as well as people abroad, then you're in the right place. With each episode, we meet someone who was working behind the scenes in global development, learning about what they did, why they did it, and why it still matters today, even as we watch the U.S. take a huge step back in foreign assistance. Today, we're going to be meeting George Siberry, the former Chief Medical Officer for USAID in the Office of HIV and AIDS. He is fun, intelligent, and was an amazing colleague to work with. So I look forward to introducing you to George. Let's go meet him. Hi, George. Welcome
Hi, Leah.
to Global Development Interrupted. I'm very excited to have you on the show, mostly because I also miss talking to you every week. All right, so USAID. We're going to start talking about it, but before we get into it, I'm going to start with your full name, which state you're calling from, and then what was your official USAID title?
Sure. So my full name is George Kelly Siberry. At USAID, I was the Chief Medical Officer for the Office of HIV/AIDS in the Bureau for Global Health. And I am calling now from New Jersey, where I was born and now live again after many years away. And I think I answered all the questions you asked.
One of the other things that we're going to do before we get into our discussion is the icebreaker question. What was your go-to fun fact?
I think the one I would most often use when we had to have like an icebreaker or fun fact was that I was a church organist from the time I was about 10 years old through the end of high school.
That was your fun fact. You used that quite a bit.
I
But I will say your other fun fact that like maybe gets pulled out in stories later was you were held hostage in Haiti.
That is true, yes.
And what were you doing there? What were you doing in Haiti in the 80s?
So after, I'm old, so it was right after I graduated college and before medical school. I spent a year there in an educational development project, one of the most formative years of my life. And it was that 88 to 89, which was a time when I think they had 3 coups in the space of that year.
But George, what happened? How did you get held hostage?
While I was in Haiti, I set up a school, a secondary school for boys and girls. And so I liked to take the teachers, the staff out. We'd gone downtown to one of the restaurants there. And we're on the way back from that. And that's when you could start hearing gunfire. You see the tires burning in the streets. And we tried to get back, but we got stopped by armed soldiers who climbed into our vehicle, commandeered the vehicle, and then made us drive them around. They didn't shoot anybody, but they did shoot their guns out of the windows of our car as they were driving us around and debating whether to take us somewhere and keep us or not. I think we fortunately just weren't useful enough to them.
But before you made it to Haiti and got held hostage and found to be less than valuable by those that took you hostage, let's start with where did you grow up?
So I'm a Jersey boy by birth. Both my parents born and bred in North Jersey. So that was a big part of my identity and really proud of our sort of poly-European heritage. And then in second grade, we moved out to Illinois. We spent about 8 years there, and I really liked it. And then in the middle of my junior year of high school, we moved back to New Jersey.
So you were focused towards going to medical school. It sounds
I
like
was, yeah.
You got back to New Jersey.
I had always been interested in medicine and applied. And, I was fortunate to get into several medical schools.
And when did you enter medical school?
1989.
What was happening around HIV at that time?
I mean, that was, they were just figuring out what the virus was, coming up with the name for the virus. Stigma was at an all-time high, ignorance and a complete lack of any tools to know, how to prevent it, let alone treat it. There was nothing.
It makes me think too, I don't think people realize how high the stigma was, but there was a seminal moment in media when Barbara Bush held a baby that was HIV infected. And I think they said, like, how could you hold this child? Aren't you scared? And she said, no, this is a child that deserves our respect or kindness. But she demonstrated that it was okay to touch a person who was HIV infected. And what a moment that was.
It was huge. And I think when you have a connection or a personal interaction that breaks down stigma in a huge way.
All right. So, medical school, you graduated from medical school and you thought, I'm going to be a.
Yeah, right. I remember when I wrote my medical school essay, I said I was either going to be a pediatrician or a geriatrician. But kids won out. Let me tell you one other relevant story that ties this all together. So when I got to medical school, I signed up to be a Haitian Creole translator for the hospital because, that was something I could offer.
Wait, where were you? Which hospital?
At Hopkins Hospital in
Okay.
Baltimore, I got called to translate for a 4-year-old Haitian boy being seen by the GI doctor because of bloody diarrhea, and translated for them. And of course, he ended up having HIV. And so I then went with him and his family to the pediatric HIV clinic there to translate again. And the person who was running that clinic, Dr. Nancy Hutton, rock star. I mean, her name should be, known by everybody who cares about pediatric HIV.
Can you give
She
us a
was a,
timeline? So, where are
this
we?
is this is 1990, maybe 91.
So, there weren't a lot of options for
There
children.
were not. And Nancy Hutton, was a general pediatrician who was actually very interested in how to do a better job with primary care for urban disadvantaged kids and families. So she never planned to be an infectious disease doctor. She was and is a phenomenal general pediatrician. And that is how she approached it. She was there to meet and care for kids and their families who had HIV, who were sick, who were dying of HIV, to do everything she could for them when there was very little available, for specific treatments. And I learned so much from that approach because that is what made the difference to those families. And over time, when we did have more treatments and specifics, she of course learned those and brought that in. But I think her model was still, it's not just that medicine that was an HIV treatment. It was the approach to health for the child and his or her family overall that was gonna lead to the outcomes that we wanted. Because we saw plenty of times, even when we had medicines, the kids who weren't able to take them for whatever reason, right? Or their parents weren't able to make sure they took them. They don't work, right? If you don't take them. But if you're paying attention to all their health needs and the other factors that influence health in their lives, man, the success was great. So I asked Dr. Hutton, could I sort of become the trainee doctor longitudinally for this child under your mentorship and in the HIV clinic?
George, you're bold.
I know. What a nerve I had, right, to ask that. Although I knew that they'd need me for the translating, at least until
I
the
like
kids
it. Be
family learned
bold.
English. And she was so gracious and let me do that. And Leah, I kept that up for, 10 years until he died. It was a shame because he died sort of just before protease inhibitors and effective antiretroviral therapy was sort of readily available.
Which is the medicine that was used to fight HIV infection with.
Yes. Life-saving, right? Made a big difference. So that longitudinal experience just tied and brought things together for me in a way, right, that I always look back on, but that also brought together kind of the clinical learning, the science learning, the need to be connected, in a human way to kids and families.
I think we often hear it as the human-centered approach, which you nicely articulated in a person is not just a being that takes a pill. There are many aspects that influence how that person gets the pill, if they take the pill, why they take the pill, why they don't take the pill.
Oh my gosh. Yes.
All of it.
But you know what? We also, especially at a time when we desperately needed progress and innovation, counted on people specializing in developing those medicines and figuring out how to try them and then making them available, right?
Just reflecting on the innovations, having those innovations continue to evolve. I mean,
Sure.
just within pediatrics with the medication, it was from when I started with HIV. It was the syrup that tasted terrible.
Oh, yes.
And then, but that was great because you could give it to babies, but could you get it to babies? I tried to give my child antibiotics when she was 6 months, and that did not go well. So,
Right.
and that wasn't like life threatening. I mean, it could have
And
been.
that was probably for a week or two, right?
10 days. Yeah, it was awful and I hated it. And this is for the rest of the child's life. But then
Right.
it moved into granules and things that were smaller and more palatable. And those are also important pieces to this whole puzzle as well.
Absolutely.
Yeah. Okay. So we've already started talking about this. So you went to USAID. How did you get
I
there? How
did.
did you get to USAID?
Leah, my first move in government was to NIH, National Institutes of Health, Child Health Institute. And so I was there from 2008 until about 2015. There, it was a chance to focus on shaping and driving and supporting the research to advance pediatric and maternal HIV prevention, treatment, care. And towards the end of my stay, I was spending a lot more time and had a lot more interest on the implementation science side of things. Because by that time, we had pretty good medicines. We understood how to do testing, both diagnostic and for following people up. And we had some good prevention options as well. But we just were doing a miserable job, especially in the global settings, although in the US as well, of really scaling and delivering those effective interventions so they could have impact. That implementation science is what actually got me more connected into PEPFAR.
And PEPFAR is?
PEPFAR, the President's Emergency Plan for AIDS Relief.
Yes.
George Bush II, that was one of his signature achievements, and he deserves a lot of credit for really highlighting that, for putting the focus on it, putting huge resources, talking about it. And that started in 2003, 2004. And it was a big deal.
You joined at a good time, NIH.
I did, yes. So, I mean, NIH was not as directly, it had a role to play in PEPFAR, but not the big role that some of the other agencies did who were more directly involved in getting things implemented.
And is that why you transferred to state? Because state was the agency that held PEPFAR.
Right, because at that point, I really was much more interested in how to get these terrific interventions where they needed to be and working right and having their impact.
So from state, you moved over to USAID as the medical officer? Was that just the flip?
I did, yes. And that was in 2018.
And is there a moment that you have in your heart where you just thought, this is why I do it? This is my example to the world of why I'm part of this agency, USAID.
I mean, there were so many moments there, like in country. Like I remember going to Kenya, and I, had been very interested in, for a couple of years, before the last year, of saying, look, we know we need to find a way with all we're doing for HIV to bring it into the mainstream more completely for how health is delivered and how people are served.
Connecting back to Dr. Hutton?
Absolutely.
Where do we help the whole family, the whole person with the disease?
Correct. Remember, Dr. Hutton's HIV clinic was embedded in the general pediatric and adolescent clinic, because that's where she knew that everything could be sort of taken care of. And there wouldn't be, kids wouldn't be stigmatized because they were coming to see her, because there were all kinds of kids coming for all kinds of things to see all sorts of people in that clinic.
Okay, so Dr. Hutton, and now we're in Kenya, and you're seeing the same need, this need to bring it into primary care.
Yeah, and we traveled out to one of the counties outside of Nairobi to see a medical center that had HIV services and that also had general medical services for people that had chronic diseases or acute diseases. And we went there because this medical director, on her own, had said, look, this makes no sense. We've got these sort of artificial barriers for a place and people to only do HIV when that's not necessarily what the demand is on a given day. Some days it's more, some days it's less. And then we're understaffed for some of these other things. But then the people with HIV also need help with their TB and with their hypertension and maybe with their asthma, right? Whatever else that they were there for. And so she sort of built interest in her own staff to say, look, medical officers, that's what they call their doctors there, or clinical officers. I don't want you to be an HIV clinical officer, TB clinical officer, or another kind. You're all clinical officers, and I expect you to all understand and know how to manage the routine management of all of these diseases. So she had actually created, implemented in that small scale, in that one place, exactly what so many of us had been talking about, but on a real theoretical scale. And so for me, that's an example of seeing exciting ideas actually take place on a small scale, knowing it's possible, and gave me evidence and gave me ideas for how to then bring it out on a much more broader scale.
And something that was very owned locally.
Yeah, and I'll say two things about that, the USAID part and then sort of the Kenyan Health Services part. I think USAID had been really trying to find ways to have that more integrated approach. And it was struggling just because of how the different programs were set up and authorized and kind of rules around it. And our USAID Kenya team, the Kenyans there who lived and worked at it, they absolutely were encouraging it, giving people ideas. So I think that they contributed to this specific medical director taking her own initiative because she had information, she had sort of positive influence, and she had that support. So I do want to sort of recognize that it created a favorable environment for this smart and motivated person to create something.
USA didn't have a top-down approach, but gave space and energy towards this woman to allow her to do what she was able to do.
Yes, and I feel like that is what technical assistance really is. The Kenyan government, and I would say national governments generally, a lot of them also had good and strong ideas about how their health system could best deliver what was needed to the most people for the greatest impact, right? I mean, they never had enough resources to do everything they wanted or in the perfect ways. But I think they had motivation, they had appreciation, understanding of the context, because it was their context. This is where, Leah, I think that PEPFAR lost its way a little bit in recent years. It was an emergency early on. People are dying, droves. And even the acceleration to get more and more people with HIV onto treatment, that was also, no holds barred. We got to get it done. Come a few years ago, we were at a point where we actually needed to be thinking, well, how are we making sure that we are planning in a way that fits with the government's vision for how it does health so that they can agree with it, they can afford it, they can actually embed and sustain it increasingly with their own, not just leadership, but resources over time. And I think that kept forcing national governments to accept what we thought was going to be the sophisticated, special way to get that last mile of HIV specific work done without thinking about the greater health context, and frankly, therefore, without thinking about how it would fall off a cliff, all the HIV gains, if we built it that way and then just dropped it all of a sudden.
So, George, we don't work at USAID anymore. It all came to sort of a screeching halt after January 20th of 2025. So when you think about now, everything that we were doing, what are you worried about when you're seeing what has happened with USAID being dismantled and the State Department taking over?
Well, let me start just by saying, this was such an assault on all of us, on the world, the way this happened. It was abusive. It was done in the name of fraudulent reasons, and it was incredibly waste-producing. For me, it was a time of grief for me, and I think for many of us, and all the different feelings that go with that. I was angry. I was sad. I was a little hopeless and not sure, what could come next. And I think that is hard when you hit people that hard in this way. And I'll say now, that like so many things that we grieve for, you process it. I've been able to process it, and now just sort of commit to making sure that I'm back in the game for the long run to make sure that we do get things back on the right path. So I'm going to start with that. I had this naive hope that maybe a new sort of political leadership would shake things up in a way that it did need to be shaken up, right? We've been talking about the fact that PEPFAR and global health, they were overdue for reform. We had some things that we really needed to, frankly, change so that we could do more good and achieve more with whatever we invested in it. There was some hope that a shakeup could be just what we needed. Instead, they came in, though, with a sledgehammer and destroyed it all. And I think what bothers me so much is it is easy to quickly destroy everything and destroy what took decades to develop and build. And no matter how much money and interest we had, it will take many, many years to try to build back or build up something that's going to try to serve the most important goals here. So that's what worries me, is that the destruction has been so sort of down to the beams, down to the foundation, that we can't turn things back on.
And the trust with our partner governments.
Absolutely. That is probably even more important than some of these other systems and structures. The trust with partner governments, trust with the communities that we were in partnership with and building things with, trust of other countries, trust of multilateral organizations. They'll all, I think, appropriately look askance, when thinking about how to interact with us now.
Yeah, and not just for the immediate,
No, this is our lifetimes. If we work really hard and people are interested in it, maybe in our lifetimes we'll see it mitigated, but it is going to be a long, hard road, and who could blame anybody who would be skeptical and not willing to trust. The only I won't even call it a positive, but the only thing that we would leverage for good about having destroyed things so completely is that you are able to put something together that is not constrained by how it got there. So just like that house that's got all those parts and you want to try to wire it anew, it's really hard to do with all those parts that were added on. But if something took the whole house away and you build it fresh, you can actually build it just the way you want it, having learned from all those decades, but also knowing now what you want to do next. So let's take advantage of the terrible things that's been done of destroying to say this should make it easier for us to build this together the way that it needs to be built. I also think the destruction has to stop before we can start to stabilize and build, and I don't know if it's done yet. I will say it may not be the worst idea to have a State Department, single global health bureau, whatever they call it now, that is responsible for all of the U.S. government global health work. Because that, Leah, means that we won't be looking at HIV by itself. We will be looking at it in the context of TB, malaria, diarrhea, malnutrition, vaccines, maternal-child health. So I think if we have the right leadership and if we can get the funding and authorization to be different, to say, here is, we can talk about all the important, we'll come back and talk about the important reasons for doing global health at all, but let's assume we agree that it's in the U.S. interest to promote advancing global health. Then instead of them saying, and we want to see HIV advance, this should say, we want to see the outcomes, health outcomes, principal and sort of most meaningful health outcomes for children and for adolescents, for pregnant women and adults in general, improve in the countries that have a long way to go and would benefit from our partnership. If you've got state being able to think about how you deliver health and not just single disease care, and think about the right balance of resources that are bringing commodities and expertise in the areas that matter most in a given context, because it's not the same everywhere, I think that could actually have real advantages. And working in true partnership with the national governments, who of course are best placed to understand what their priorities are and how their systems work. Is that crazy?
Well, I don't know. I'm going to have to ask other people if they think that's crazy. But I don't think holistic health is crazy. And I do know that there was a lot of poor feelings across agencies. So I see your point of view of if it's in one house and working as a collective, not just on specific siloed diseases, but how do we help the person within a community that resides in this country ensure that they can have a long, stable life. I can see how that would be productive use of taxpayer dollars.
Yep, you said it way better than I did.
Is that your hope for the future?
That, if someone asked me how I think if we were actually interested in doing it, right? I'm still waiting to see if we're genuinely interested in continuing to support global health. But if we are, I think that's where I would want to start. I do. A little bit more like the way the president's malaria initiative focused. A single agency was responsible for all of it. It counted heavily on technical experts from CDC, but it had that unity of leadership, which was helpful. But it was still a single disease program, and that's why I'm saying now you take that a step up and say health.
Okay, so George, why should Americans care about global?
I think there are several reasons, and one thing I'll start with is I hope that we can convince and reassure people that you don't have to choose between making sure that our government is using its resources and expertise to better the lives and serve people in the United States who, are having a tough time every day. Choose between that and choosing to support global health. It was something like 1%. That might have been foreign assistance overall.
Yeah, it was foreign assistance was less than 1%, maybe 0.7% of the federal budget.
Right. So only a portion of that was even health assistance. It's not like we can't afford it. I think we can afford it. It is something that we have been doing all along, and it isn't what's been breaking the bank. You don't have to choose one or the other. You say both are important and do both.
And George Bush proved it.
He totally did. Yes, but why else? So, I think when we worked together in COVID, it helped bring COVID under control way more quickly than if people weren't working together. There will be other epidemics. There'll be old epidemics that creep back up. And, through global health assistance, we are in better communication, have better systems and structures to identify and respond and contain those things so that they don't actually get out of control in the United States. The other example, I think, for HIV, for TB, for malaria, right? Those are problems that are not as big of a burden in the United States, but we absolutely have people in every state in this country who are confronted by those illnesses. We will not be able to continue to innovate and develop new tests and treatments and prevention interventions if we only work within our borders. We just don't have enough people who could help us learn what we need to be able to do that. And so what we saw, right, is in our global partnership in HIV, we really moved a lot faster in learning, for instance, how to treat babies and young kids with easier to take, effective, well-tolerated drugs. And those then benefited the kids in this country who needed them. They're not as many, but they absolutely benefited. And I'll give you a great example. Infant feeding. Up until just a couple of years ago, the United States and its federal and professional society guidelines just automatically and categorically said, if you have HIV in the United States, you do not breastfeed. Because HIV can be transmitted through breastfeeding. We know that. And we've got safe alternatives formula. Of course, the context is totally different in a lot of high HIV burden places, like places in Africa, where doing something other than breastfeeding actually increased the chance of babies getting sick and dying beyond the risk of them actually contracting HIV through breast milk. And we learned through careful, ethical, community participating, thoughtful trials that when women had access to HIV drugs and were supported to be able to take those, and then giving baby prevention drugs after birth as well, we could let women safely breastfeed even though they had HIV without worrying that their babies were going to be infected. Women in this country said, look, this is what we've learned. This is science. This is evidence. Why are you still telling us categorically that just because we have HIV in this country, even though we are on treatment and we know we're suppressed, that we can't make our choice about feeding? And so, because of that, because of what we learned through there are international collaborations. Over the past couple of years, the NIH federal guidelines for HIV and pregnancy and the American Academy of Pediatrics both now wholeheartedly support shared decision making for women with HIV who are on treatment in the United States, to learn about the options, the pros and cons, for them to make that decision. And many do, because the breastfeeding is so important to them, the attachment, the other benefits to the baby, and the reassurance that there's a lot of science saying that as long as I'm on my medicine, I'm not worried about passing the HIV along. So that is one of my favorite examples, but these are the examples that happen when you work together, right? For diseases that are more in one place than the other, but sort of present everywhere to some degree.
Well, and then it's just the point of you don't get smarter talking to yourself.
I like that too. Look, I'll finish off the, why should Americans support global health by saying, because we've seen it in the communities that we visited when we went on our site visits when we were working for PEPFAR. It creates a lot of goodwill and a very positive reputation in the colleagues in government there, but also just in the business community, the community, just the population at large. And that positive reputation, that goodwill, and that sort of, America's smart and generous and helpful and here doing good, that counts a lot when problems arise of all different sorts. That's a population and a government that we can probably count on more heavily. And you know what? If we're not building that friendship and good reputation and goodwill, well, you can bet that China and Russia will be in there to fill the void and get that influence. So, if we want to stop growth of terrorism, if we want markets for our businesses, if we want sort of solid sort of political partners and just, let's face it, friendly nations, this kind of global health assistance, global aid in general, I think is a really effective, if hard to measure, way to do it.
Yeah, well, and you don't want to do business with people you don't trust. And
I think that's right.
And taking away healthcare from millions that relied on it so abruptly, that's a really good way of breaking trust.
That's right. Even if you could make an argument that it wasn't the U.S.'s responsibility to begin with, that doesn't excuse the fact that we were taking some responsibility, and without warning, we suddenly took it away.
Yeah, and lives lost because of it.
Absolutely. Immediately, and more infections, and it's... Yes.
George, one of the things that I hear a lot is, well, we don't need to worry about government removing support because we will just rely on philanthropy. What is your response to that point of view?
There's a role for philanthropy. There has always been a role for philanthropy. They can bring money to things that government's not allowed to do, but that is important. I want to highlight that I think philanthropy has they have important roles. They've been playing those roles. But I still believe that government operates on a scale and for a purpose different from what philanthropies do. When government turns its attention to something, it can do things that nobody else can do, including philanthropy. But the second is purpose. Philanthropies have their own objectives, their own interests, their own philosophies, perhaps, agendas. That is where they are going to direct their funding, to their interests. And there are many wonderful things that Gates, for instance, does. And so a lot of what they do, of course, does align with what I think the national interests are, what the U.S. interests are. But if the U.S. government is doing something, then they are supposed to be doing it in a way that represents the national interests. And I think that is an important difference, that is sort of the core, this large scale, reflecting the national interest investment in global health that you wouldn't get if we left it all to philanthropies.
Beautifully said. Okay, now we're going to ask the question to close this up. What is the one thing that you hope listeners take away from our conversation?
I hope people understand the incredible successes that we've had through global health work. Just phenomenal, unbelievable. And I want people to feel the positive attitude and energy coming from me and hopefully lots of other people, that we can chart a path, even if it looks different, to get back to doing terrific things through and with our government over time. That's my hope. We are at this very rough patch, but I remain optimistic that this is terrible but temporary, and that we will be able to find a way to get back on track.
And you got to keep pushing. You got to keep saying what you want out of the world if you want to see it come forward.
And don't be afraid to do that, right? I'm less interested in calling people names and complaining about people and decrying what people have done, and more interested in trying to talk positively, openly, and creatively about what we can do next.
So you've hit all 5 stages of grief, and we are now at acceptance.
It's true.
Okay, well, George, it was such a pleasure having you on, and I am so glad that we got to talk.
Leah, thank you. This has been such a highlight for me, such a joy, and I hope we can talk again in not too long from now about how we are getting things back on track.
Me too. This is Leah. If you've enjoyed this conversation and would like to hear more, please subscribe on Substack or follow along on Apple Podcasts or Spotify or wherever you get your podcasts. Until next time.